Welcome to day 2 of the EULAR Virtual Congress 2021. My name is Dr. Elena Nikiphorou. I'm a consultant rheumatologist at King's College Hospital and an adjunct senior lecturer at King's College London. I'm delighted to bring you my highlights from day 2 of the Congress, which included a number of sessions on rheumatoid arthritis with featured abstract sessions on biological DMARDs, non-biological treatment and small molecules, and prognosis, predictors, and outcome. In this review of the day, I will share with you key abstracts and chairman's picks on real-world data, clinical results in RA and other indications, data on difficult-to-treat patients, and pain. There's a lot I'd like to share with you, so let's get started. Following on from the wealth of real-world data that Professor Douglas Veal highlighted yesterday, I'd like to take you through some abstracts. The first comes from Barbulescu and colleagues and compares the effectiveness of JAK inhibitors and biological DMARDs in rheumatoid arthritis patients in Sweden. This was a retrospective observational study to compare RA patients treated with biological DMARDs and JAK inhibitors in Sweden using the Swedish Rheumatology Quality Register. And outcome measures included patient characteristics at treatment start, proportions of patients remaining on therapy, and response rates at 12 months. Interestingly, in this study, JAK inhibitors showed lower overall responder proportions than TNF inhibitors, rituximab, and interleukin-6 inhibitors. The take-home message from this study was that there was no significant difference in effectiveness between JAK inhibitors and biological DMARDs. One of the chairman's picks, the next abstract, comes from Kalioncu and colleagues in Turkey. This abstract assessed the real-life efficacy and safety of tofacitinib in patients with rheumatoid arthritis-associated interstitial lung disease. This observational study included patients followed at 8 different centers that participated in the TREASURE database. This was an observational study across the 8 centers participating in the TREASURE database. The key results were as follows. RA patients with interstitial lung disease receiving tofacitinib were mostly male, older, and had higher baseline disease activity as compared with those without ILD. The most common reason for discontinuation in RA-ILD was infections, seen in about a quarter of patients. Follow-up duration under tofacitinib was 15 and 11 months in ILD positive and ILD negative groups, respectively. So the take-home message from this study is that pulmonary function remains stable in the majority of patients during follow-up. Tofacitinib may be a promising, therefore, option for RA-ILD. Hernandez Cruz and colleagues from Spain presented data from a multi-center real-world dataset comparing the safety profile of JAK inhibitors versus TNF inhibitors in patients with rheumatoid arthritis, ankylosing spondylitis, and psoriatic arthritis. This is another of the CSF chairman's picks. I recommend you access all these presentations online if you haven't been able to see them yet. So this study showed that JAK inhibitor patients were older and with a mean disease duration of 10 years. JAK inhibitors were prescribed as first-line treatment in about a quarter of the patients. The main reason for stopping treatment was ineffectiveness followed by adverse events, and survival during the first year was similar between groups. So in conclusion, serious infections and herpes zoster tend to be more frequent in patients on JAK inhibitors. However, patients on JAK inhibitors in this study were older, presented higher comorbidity, and had a longer disease duration. Stromfeld and colleagues presented our final chairman's pick of the real-world data. They analyzed data from a cohort of RA patients aged 70 or older, enrolled in the German Rabbit Registry with a new start of a DMARD after at least one conventional synthetic DMARD failure. The analysis aimed to assess whether there was an increased risk of serious infections in older patients when receiving biological DMARD or JAK inhibitors compared with conventional synthetic DMARD treatment. And this study concluded that treatment with JAK inhibitors or biological DMARDs was not associated with an increased risk of serious incidents in elderly patients above 70 years of age. And this was reassuring. In my final selection of real-world data from day 2, Bergman and colleagues aimed to describe the patient characteristics and outcomes in patients with rheumatoid arthritis treated with upadacitinib using data from the OM1RA registry. The key results in this study were as follows. The majority of patients were female, that was around 83%, and had prior treatment with a biologic, that was 3/4 of the patients. The mean change in CDAI was minus 5.1 in the monotherapy group and minus 5.9 in the combination group post-upadacitinib initiation. Okay, so the main take-home message from this study was that upadacitinib provided sustained significant improvements in disease activity, regardless of monotherapy, combination therapy, or prior targeted immunomodulatory drug therapy. Similarly to yesterday, there was a good amount of clinical data in rheumatoid arthritis presented at the Congress. The next highlighted abstract is another chairman's pick. This one comes from Charles Scheumann and colleagues and uses data from the phase 3 SELECT clinical program to describe integrated laboratory abnormality profiles of upadacitinib with up to 4.5 years exposure in patients with rheumatoid arthritis. So the main message from this study was that UPA-treated patients showed dose-dependent relationships for several lab abnormalities, which were typically higher in the UPA-15 group than adalimumab, but similar to methotrexate, except for elevations in creatinine phosphokinase. There was an interesting poster presented by Van Lint and colleagues. In this study, they assessed the adverse events of JAK inhibitors on glucose levels in diabetic patients with rheumatic diseases and other immune-mediated inflammatory diseases. The results have implications for the management of patients with diabetes when starting a JAK inhibitor. So the key results in this study were as follows. Hypoglycemia and decreased blood glucose was reported in 16 and 15 patients respectively. Increased insulin sensitivity was described as a suspected adverse drug reaction of baricitinib in one case. Additionally, in 6 cases, there were improvements of glycemic control described after discontinuation or dose reduction of the JAK inhibitor or an anti-diabetic drug. So in conclusion, JAK inhibitors may induce hypoglycemia by increasing insulin sensitivity and consequently may reduce the need for anti-diabetic medication. This was the main message from this study. There were a number of presentations today which interrogated data from large rheumatoid arthritis clinical trial programs. Professor Peter Taylor's group presented a poster investigating whether there are improvements in patient-reported outcomes across all disease activity levels when baricitinib is compared to placebo or adalimumab in rheumatoid arthritis. Data for this analysis were derived from the RA-BEAM phase 3 study. The main concluding message from this study was as follows. This study showed that patients using baricitinib 4 milligrams may experience greater improvement in patient-reported outcomes than placebo or adalimumab, regardless of disease activity status after 12 weeks. Bergman and colleagues evaluated the impact of upadacitinib versus comparators over 60 weeks on the routine assessment of patient index data 3, known as RAPID-3, in a post-hoc analysis of the placebo-controlled and active comparator-controlled studies in the SELECT clinical trial program. The correlation of RAPID-3 scores with other disease measures in the SELECT phase 3 clinical trial program was also evaluated. The key results were as follows. There was improvement in RAPID-3 observed with upadacitinib 15 milligrams and 30 milligrams through week 60, with numerically greater improvements compared with active comparators. RAPID-3 scores were moderately to strongly correlated with CDAI SDI and DAS28 using CRP across all studies at week 60, all with a p-value of less than 0.001. In conclusion, this study showed that upadacitinib as mono or combination therapy was associated with improvements in patient-reported disease activity, pain, and physical function as assessed by RAPID-3 over 60 weeks. Clinical responses to upadacitinib or abatacept in patients with rheumatoid arthritis by number and mechanism of action of prior biologic DMARD were investigated by Rupert Roth and colleagues. Data was collected as part of the phase 3 Select Choice study of patients with inadequate response or intolerance to biologic DMARDs. So the key message from this study was that upadacitinib led to greater clinical responses versus abatacept at week 12, including in patients with loss of efficacy to TNF inhibitors or interleukin-6 inhibitors, and those with inadequate response or intolerance to 1, 2, or 3 or more prior biological DMARDs. Moving away from rheumatoid arthritis for a moment, Day 2 has given us great presentations of clinical results in indications other than RA. I'd like to share with you my top picks from the day, focusing on ankylosing spondylitis and psoriatic arthritis. The first is also one of Ian McInnes's chairman's picks of the Congress and comes from Deodar and colleagues who report the efficacy and safety of upadacitinib in patients with ankylosing spondylitis from the Select Axis study. The one-year results were presented and showed sustained and consistent efficacy of upadacitinib 15 milligrams 4 times daily. This study concludes that the use of upadacitinib 15 milligrams once a day showed sustained and consistent efficacy over 1 year, even in patients initially randomized to placebo. Staying with ankylosing spondylitis, my next highlight is also a chairman's pick. Baraliakos and colleagues undertook a post-hoc analysis to evaluate the effects of filgotinib on spinal lesions over 12 weeks in the Tortuga trial. MRI data on spinal inflammation and structural lesions were examined. This was the first placebo-controlled trial to demonstrate a decrease in inflammatory activity with filgotinib in the spinal vertebrae and the posterolateral elements of the spine and the facet joints. The last of my selection of clinical results from day 2 comes from Professor Laure Gossek's group and is an interesting investigation into the link between probable depression and/or anxiety, inflammation, and tofacitinib effectiveness in patients with psoriatic arthritis. This was a post-hoc analysis of data pulled from 2 phase 3 trials, the OPAL Broaden and OPAL Beyond. In this study, patients with a major depressive disorder or a generalized anxiety disorder at baseline who were treated with tofacitinib showed a sustained change in their SF36 MCS. Pain management is an important area for clinical practice, and providing the best possible care for our patients was featured in several abstracts presented today. I encourage you to try to find the opportunity to seek out the abstracts on pain if you weren't able to see them live. They really do provide an insight into what our patients are experiencing and ways in which we can support them. My first pick is an abstract from Gwinnett and colleagues from the UK and France, who identified a subgroup of people with rheumatoid arthritis characterized by high levels of disability despite low inflammation. The results underline the need for pain and fatigue management even when inflammation is low. It was interesting to see in this study that at baseline, the high HAC groups in both the NOR UK cohort and the ESPOIR French cohort were older, had a higher proportion of women, and had higher levels of fatigue too. So this study concludes that there is a group of people with RA with high levels of disability despite low inflammation. My final pick of the day 2 content focus on pain in our CSF Meet the Expert session, supported by Lily, how to provide patients remission they can feel. This was with Professors Hendrik Schulz-Koopes and Bernard Koob. Professor Schulz-Koopes described remission in rheumatoid arthritis and reviewed which definition provides patients with remission they can feel. Professor Koob followed this with a presentation focused on the results of studies that demonstrate that pain improvement is a key goal for patients and that pain can persist despite achieving low disease activity or remission. The discussion provided some fascinating insights. Do make an effort to catch this one if you've missed it. It's only half an hour and well worth a watch. Similarly to yesterday, there were some interesting and engaging industry-sponsored sessions today. There were 2 Meet the Expert sessions of note. The first, supported by Pfizer, featured Professor Gerd Rudiger-Burmester and Professor Laura Coates discussing personalizing patient care, reflections on the place of JAK inhibitors in rheumatology. The AbbVie Meet the Expert session was an interactive clinical case discussion on optimizing disease outcomes with the use of JAK inhibitors in the management of RA and SPA, led by Professor Andrea Rubert-Roth and Dr. Janet Pope. These half-an-hour sessions are a great bite-sized insight into pertinent topics and always have a good level of discussion. There were 2 symposiums of interest today. Our CSF symposium on COVID-19, supported by AbbVie on the management of patients with rheumatic musculoskeletal diseases, was chaired by Professor Leonard Calabrese and included presentations from Professors Kimi Heirik, Robert Landauer, and Chris Edwards. This was a fascinating session with discussion of what we have learned from COVID-19 global registries, treatment guidance for patients with RA in the COVID-19 era, and what the new normal may look like in terms of telemedicine and communication. I conclude my summary of today's highlights of EULAR 2021 with the second of the Galapagos symposiums in Darwin's footsteps. You will recall we featured the first in this series yesterday. Today's symposium was chaired by Professor Maxime Dougados and explored the role of JAK inhibitors within the diverging RA treatment landscape. Professor Dougados was joined by Professor Ricky Alten, Dr. Kevin Withrop, and Professor Ernest Choi, who covered exploration of living with rheumatoid arthritis and translating clinical features of different treatments to meet patient needs. Thank you for joining me for this summary of the Day 2 highlights from the Congress. I have really enjoyed sharing some of the picks of the content with you. If you haven't already, you can download our EULAR 2021 highlights brochure from cytokinesignaling.com to see the abstracts that we've selected for you for the whole of the Congress, along with Ian McInnes, Chairman's picks. Professor Douglas Veal will be back with you tomorrow with his highlights from Day 3, and I will be back on Saturday with a roundup from the final day. Until then, keep enjoying the Congress.